Hello and welcome to the Digital Scholar webinar series hosted by the Southern California Clinical and Translational Science Institute, University of Southern California and Children's Hospital, LA. My name is Eric Peterson. I am the co-director of digital recruitment within the CTSI and also an associate professor of psychiatry in the Keck School of Medicine. Please, if you're interested, follow us on Twitter. It's my handle as well as the SCCTSI one, where you can find out about more of our events. Before I introduce the speaker today, I just want to take you through how this works. I know many of you are very familiar with Zoom, but if you look at the bottom, you can see something that says Q&A. If you want to click on that at any point during the talk, you can ask a question. Our speaker today is going to field questions at the end, and I'll help facilitate that. So you can put in a question at any time, and then I'll read it out at the end. There's also time for questions at the end as well. So if you want to wait till the end to type in your question, that's totally fine too. And so we're excited today to host Dr. Matthew Chinman, who's a very close colleague of mine. I'm very excited he agreed to do this. He's going to be talking with us today about getting to outcomes, which is an approach that helps community organizations set up programs across a wide range of topic areas. And in this presentation today, Dr. Chinman will summarize the Getting to Outcomes approach, or also known as GTO, the GTO approach and the research behind it, which he is quite capable of doing, given that he is a co-developer of GTO. In addition, he's going to present on the tools and materials that GTO has available to support community organizations and researchers as well. Just a little bit of background on Dr. Chinman. He is a senior behavioral scientist at the RAND Corporation based out of Pittsburgh. And his focus has been on developing strategies to enhance the prevention capacity of community-based prevention practitioners. As I mentioned, he co-developed GTO, and he led the development and testing of several GTO-based guides that are aimed at assisting local communities in planning, implementing, and evaluating prevention programs in many different areas. But to name a few specific ones: substance abuse prevention, underage drinking prevention, teen pregnancy prevention, homelessness, and youth development. Dr. Chinman is also a health science specialist at the Mental Illness Research, Education, and Clinical Center, or the MIRAC, at the Pittsburgh VA Medical Center. And his overall focus there is on developing and testing various interventions to improve the recovery of individuals with serious mental illness. And so now I will turn it over to Dr. Chinman, who can share his slides, and thanks very much.
All right, thank you, Eric. I'll share my screen. Yeah, it's really nice to be here and talk about GTO. I think Eric summarized it well in terms of getting to outcomes. Really, it's an approach that helps people stand up evidence-based approaches, but also does things like tries to get people to evaluate those approaches, do quality improvement on those approaches, get them to sustain them. So it's sort of the stuff around the delivery of evidence-based programs, but also about their management as well. This approach is firmly rooted in implementation science. So I don't know if, Eric, you've had stuff on here about that before, or folks are familiar, but I'm going to sort of start with a little bit of background on implementation science, and then go to the general Getting to Outcomes approach, and then get into the early studies and then the later studies. And I split that into two buckets because we made some big changes around how we study getting to outcomes that I think have some implications for what we found. So just moving on from there. So I think folks have a sense of this, but I usually, every talk that I give on getting to outcomes, I have to kind of establish this idea that EBPs, or evidence-based programs, are often not used or applied equally across groups. So we spend so much money and time and develop all these great approaches, but then they're not used in the real world. And so that's very disheartening, and it just leads to a lot of outcomes unrealized. So, just a couple of examples in drug prevention. We know from surveys, this one's getting a little old, but the other surveys since then has shown that most schools, for example, where a majority of the prevention work is done in the country, most schools actually don't use an evidence-based approach, evidence-based program. And then even when they do, they often don't deliver them with fidelity. So that means that the activities that schools are doing are really not going to have any impact. And so it's a lot of wasted time and effort and momentum. And then also more lately, I've been sort of applying this idea to health disparities. And there's tons of evidence across a wide range of disease states around the idea that, folks of color, minorities are not getting the same level of care as whites. And multiple agencies have shown that if you could just, help, minority communities get the same level of care as majority populations, the overall quality and outcomes would be dramatically improved. So what gets in the way of these kinds of things? There's a lot of different barriers, resources, feasibility, momentum, priorities, inertia. There's been a lot of barriers. And the idea behind getting to outcomes is to try to address some of these barriers and build people's capacity to do better evidence-based programs, run them well, and evaluate them, improve them over time. So this is firmly rooted in implementation science. And so implementation science, for those who may or may not know, it's a relatively new field. This is the first article of the journal Implementation Science. And so that was, just in 2006. So it's a relatively new field, but it's really focused on this idea of trying to promote the systematic uptake of research findings and other evidence-based practices into routine practice. So GTO is sort of firmly rooted in that field. So here is just like these phases of clinical research, and you may be involved in all of these kinds of efforts, starting with pre-intervention, which asks the question like what to target, and then efficacy studies, what should we be delivering, what should our evidence-based practice be, and then when we get to implementation science studies, it's really how to deliver it is the question that we want to tackle. And again, GTO fits into that. And so the conceptual model of implementation research, I think is important to kind of keep in mind. So when this is sort of like the kind of the general kind of efficacy studies, which is like, what are we going to deliver? And then what are the outcomes? And so that's sort of the usual case. But in implementation science, we want to have a sense of, well, how does that delivery happen? And so there's something called implementation strategies, which is these are techniques or activities that are aimed to make implementation of your approach better and make it happen more consistently. And so GTO is sort of an example of an implementation strategy. It actually has multiple strategies within it. And sometimes we call that sort of an implementation strategy bundle. So that's part of this conceptual model here. And then outcomes that we are interested in addition to patient outcomes, are things like under implementation outcomes, feasibility. Fidelity is a big part of what we look at in GTO research. Penetration, acceptability, sustainability, costs. These are the kind of things that implementation studies sort of focus on. And in addition to kind of service level outcomes of like efficiency and safety. So the core of implementation science really is sort of in this middle part. We also do look at patient outcomes, but the core of what I think implementation science really focuses is on these implementation strategies and implementation outcomes. Here's another look at, this is Enola Proctor, who's a huge name in the field. And these are some other kinds of, another look at these implementation outcomes that GTO also targets. So what is the GTO approach? So first I will show you sort of an embarrassing picture of myself, but so this all started back in the 90s when I was a graduate student here in my apartment with my cat, may she rest in peace, doing an evaluation report for a community that we were evaluating their drug prevention efforts. So this was a part of a larger nationwide effort by SAMHSA to fund drug prevention at the community level. They targeted 251 communities, spent $500 million, doing that over 5 years. And in South Carolina, there were 4 such communities. And so me and some colleagues got a contract to be the evaluator of their efforts. And what we found is after many years that while they worked really hard to try to do a good job with substance abuse prevention, they got really no outcomes whatsoever. So this was true in South Carolina, and it was also true nationwide. And a big thing that we saw was that they just didn't really know what to do. They brought all these community members together, so they had a lot of input from like grassroots, from criminal justice, from health, from schools, from religious communities. They had really everyone at the table, but even after all that, they really chose activities that were not really that potent, and they didn't evaluate them well. And so, I mean, at this point in our development, we were just sort of documenting all this, but we were kind of aghast at what we were watching in terms of all the hard work and money that was spent for really no outcome. So that left us feeling like, well, what can we do to help community organizations implement these, these kinds of programs and approaches better? And then how could we actually study that? If we came up with an approach, what could we do to actually evaluate that approach and see how effective it is? And that was sort of guiding us in our thinking around designing Getting to Outcomes. So Getting to Outcomes is designed to build capacity for high quality program implementation. So it's partly a model or sort of a pathway that poses 10 specific steps that we believe all communities or all programs or all organizations should go through to implement a program, stand up a program. And it's also a series of implementation supports that helps practitioners walk through those 10 steps with quality, kind of get them where they need to go. So here are the 10 steps. And they will surprise you not at all. And these are steps that we didn't necessarily create, but we wanted to put it all into a single model and try to make it as easy to digest for community-based organizations as possible. So it starts with sort of figuring out what your problem is. Step 1, that is usually a needs assessment, and we have tools to help you do that. Then there's step 2, which is you identify your goals, your target population, and your concrete desired outcomes of what you want to achieve. Then step 3 is that you find existing programs worth adopting and copying. So here we really focus on trying to pick the most evidence-based strategies around that meet your needs. Then steps 4 and 5 are kind of like filters, because in step 3, you'll identify candidate programs, and then you'll narrow that down with steps 4 and 5. So 4 is about fit. So you identify a whole range of programs, but some of them may fit into your organization more than others. So if you are at a school or an organization that has an abstinence-only policy around sex education, then choosing a sex education program that focuses on condom use is not going to be a good fit. Then capacity. So a lot of these programs, they cost money, they require special skills or technology. And so you really have to make sure, well, do we have the right capacity to actually do this program as intended? And so if you don't, that can trip you up and lead to suboptimal implementation. And so we have a whole step there around thinking about those issues. So after you narrow down your choices, you get to step 6 and you come up with your choice of what you're going to actually do to address this problem you identified in step 1. And then you do some detailed planning, the who, what, where, when. Just make sure everyone knows how to do this. And then steps 7 and 8 are really about evaluation. Step 7 is about what we call process evaluation. And so that's looking at how well your chosen activity was implemented. Did it have good fidelity? Did everyone attend? Those kinds of issues. And then step 8 is about outcome evaluation. Did people who went through the program change in the way that you wanted them to? Step 9 is about continuous quality improvement. So that's looking back across all these past steps, kind of revisiting those questions, seeing if you have different answers. So partly that's based on your data, but also it could just be looking at your plan and saying, well, did we do everything that was in our plan? You know, did we have the right target population? Did we have the right goals? So answering all those questions is a form of continuous quality improvement. And then at the end of that, you make a plan to make changes in your approach. And those could be any type of change at any step. And then you kind of proceed from there. And then step 10 is the last one, is about sustainability. We have some guidance there around how to make sure that this program, if it's working, if it's getting the outcomes you want, to make sure that it sticks around and continues to have impact in the way you want it. So it has, you know, as we lay it out, and it does have some linearity to it in terms of sort of a, you know, step 1, step 2, step 3. In reality, the GTO is not always linear, and it's more sort of like a painter's palette where you kind of bounce around to different steps, and, you know, you might make a change in, you know, your concrete objectives, which would then impact what you would then evaluate in your outcome evaluation. So you do bounce around very much. So one device that we often talk about in our trainings is that you can use GTO to plan anything. You can use it to plan a vacation, you know, like what are my goals for my vacation? You know, what are my capacities for my vacation? You can run anything with GTO. It's a very generic open model that can be applied to a lot of different content areas. So that was the sort of the model portion that I mentioned of GTO. So GTO also has these 3 parts that make it sort of an implementation strategy bundle. And so we have tools, sort of that I'll go over, written guidance. We have training, and then what we have what we call technical assistance, or TA. So our tools, we have over the years, we have written, I don't know, maybe 12, maybe more guides that apply the GTO approach to various content areas. So this one, the least attractive one here, that was GTO 2004. That was applied, it's basically taking this method and taking all the tools and applying it to substance abuse prevention. Then we applied it to something called developmental assets, which is sort of a positive youth development framework. We've applied it to homelessness in the VA and sort of the Department of Veteran Affairs. And then and as Eric said, we've done teen pregnancy, underage drinking, and most recent efforts, we've now begun to use getting to outcomes in the US military. So we started with the Air Force, and they have something called community action teams, which are like these little mini coalitions within each base that have to put together a plan to help their airmen tackle problems. So it was a natural fit. So we put together a guide for them. And then we also put together a guide specifically getting after the problem of sexual assault in the military, in the Department of Defense. So we have a guide for that. And each one of these guides is set up in the same way. And so it has each of the 10 steps. It has guidance for each of those 10 steps that you saw earlier. But then it's anchored into these different content domains. So the evidence base, sort of the step 3, the evidence base that we review in each of these manuals is different because every content area has different evidence. But they all have the similar kinds of tools. So this is on the upper part, sort of a part of a tool, and the bottom part here is just a sort of an example of how one of these tools is filled out. So this is the only example I'm going to show. We have lots of tools, but just as an example. So the idea is that these tools they're basically like prompts. They have information that prompts the user or the practitioner to make certain decisions and then record the result of those decisions. So here is what we call the goals tool, which just prompts people to come up with a SMART goal, which is specific, measurable, achievable, realistic, time-bound, and this is in step 2 that will guide the rest of their actions from there. So it'll guide what programs they choose, what outcome measures get chosen, how whether or not you met those your benchmarks. And this is from our teen pregnancy version of this manual. So you can see here, there's prompts about aligning with various components of that are important in teen pregnancy. And so here's just an example of someone who's filled this out, and they made some decisions about that they were gonna, in their program, they want a goal of kids abstaining from sex in the next 90 days, 80% at post-survey, and so forth. And so all of the GTO steps have certain tools that look like this, these sort of worksheets that prompt decisions. And we do have them available as soft copies. And as I'll mention in the end, we've tried to think about how to kind of webify this whole thing and make it a truly digital tool. And I can say a little bit about that at the end. So then we also have face-to-face training, which is sort of your standard kinds of training. It really involves walking people through the 10 steps, walking through the manual, whatever manual we're using. And then we kind of teach people about each of these 10 steps. And so it's for some of these concepts like program evaluation, we're not doing there are whole courses on program evaluation. We're trying to give people just sort of the basics they need to do a basic evaluation on whatever program they're running. We try to tailor that program to local program needs. We used to do it in sort of a more brute force way where we do do it all in one day. And now we actually break it up by step so that the training is closer to when they are actually doing those activities. So their initial preparation work was sort of that needs assessment, goal setting, and looking for programs. We'll do a training just on that. They'll go out and do that work. And then we'll do sort of the trying to decide on the evidence-based program and planning. That's steps 4 through 6. Then they'll go out and do that work. Then they'll run the program, get some data. Then we'll do like a CQI workshop where we talk about data and how to improve. So we're trying to get the training closer to the actual work rather than just hit them all at once. The biggest, really, probably the most important part of the getting to outcomes approach is technical assistance. We think of it like a coach. So, we have this, this graphic here because one way to think about it is that, no one learns how to drive a car by reading how to do it in a book. right? You have to get out there in a car and actually practice. And then usually, a lot of times, if you take a class, you might have the instructor sitting in the passenger seat with you, giving you guidance. And so our technical assistance is like that. We have meetings with sites on an ongoing basis, and we coach them through completing all the tools and taking all these necessary steps, constantly giving them feedback on how they're doing and trying to get them to improve. We've done it from using PhD level folks to BA level folks, part-time or full-time. And we're really targeting sort of the people who are running these programs, like the coordinator. Usually it's sort of twice a month, but sometimes it's been more frequent, sometimes it's been less frequent. We like to stay with people, if possible, over a 2-year period where but it's more like a 2-cycle period. So try to get people through a full cycle of running the program, getting data, improving, and then running it again, and to see if they can take those improvements and actualize them in the next cycle. So I'm going to talk a little bit about some of the early getting to outcome studies. So the first thing that we did was sort of built this GTO logic model. The idea was that our intervention, our implementation strategies and support, we wanted to see if we actually improved individual capacity. So we defined that as sort of knowledge of how to do these programs across all the 10 steps, their attitudes and their skills around it. And then what we call performance, and this is the degree to which they actually did these behaviors in a high quality way. So how well did they do planning? How well did they do evaluation? How well did they do continuous quality improvement? And so we wanted to see if we had impact on these areas, because that's kind of fits with our model. And then outcomes and implementation outcomes kind of come a little later. So we had 2 studies, and they both focused on prevention coalitions. So this is when people get together, they pull different sectors of the community together to tackle a problem. And so our GTO pilot had 2 coalitions. It was sort of the smallest of our studies, where we had GTO programs and then non-GTO programs. And then we had our assets GTO study, which was 12 coalitions in Maine. 6 coalitions got GTO and 6 didn't. They were both cluster randomized, the assets GTO by coalition. The GTO pilot was sort of quasi-experimental by state. And we basically wanted to know what I said just last slide, impact on individual capacity to run these programs, how well they did it, and then acceptability. We had PhD level psychologist in our pilot, BA prevention specialist in the assets GTO study. And then one sort of hallmark of early studies versus later is that the programs were pre-existing before we got there, and they varied widely, mostly not evidence-based programs, but they were what was in place while we got there. Also, the type of GTO guidance and coaching we did was a little bit idiosyncratic. We kind of jumped around, really letting the coalitions lead where they wanted to kind of go. And we allowed, some coalitions focused on planning, some focused on evaluation. And so there was just different emphases, and we just allowed that variability to occur. So what we found is basically there was improvement on program performance. So we actually interviewed the people who ran these programs and got them to tell us how well did you do all these steps? And then we had a standardized rating of that. And the GTO assisted programs definitely did better across most steps. And then the individuals who participated, we surveyed them on their attitudes, their knowledge, and their skill level. And they also told us that you know, they not only they improved their performance, and there was more improvement in the GTO assisted coalitions. We did a lot of qualitative work in these studies, asking people what they thought about GTO. And they basically said folks generally liked it, although it did take time. And that, you know, that was a concern. We did some follow-up analyses, and we found that there was a quantitative empirical relationship between individual capacity and performance of programs. So this was really important, is that, so there was an actual empirical link between our ratings of capacity and our ratings of performance. And that was important for us because this was our guiding model, and we wanted to see if those relationships were in fact true, that if you improve their capacity, you'll see better performance. And that was borne out by these studies. So what our lessons from this was that, you know, we could in fact do it. I mean, these were they were both sort of pilots in a way. What we did also notice was that, you know, how much existing capacity you had can can be an issue. So some side analyses found that our ratings of capacity, we found that if those who had higher capacity at baseline actually were able to increase their capacity more over the course of the study. So there was a little bit of a, you know, you needed some capacity to then take in our guidance and improve and get more capacity. Clearly, those, you had to be in it to win it, like those who did not really engage in the GTO training, because, you know, not everyone showed up at every activity, you know, then it was definitely, those communities did not get as much benefit. One of the things that was most highly valued was the evaluation support. Almost none of these communities had evaluations prior, but they all pretty much did at the end with our help. And we were able to sustain that with a local community university partnership in the state of Maine. And another point was that ongoing implementation support is helpful, but that accountability and consistent resources are also needed. You know, folks that had some level of accountability built in, that, you know, there was leaders looking at what was going on and holding their staff accountable, GTO went better in those places. So what we were not able to do in these studies was really look at an impact on actual outcomes of the recipients of these programs. So that's what we wanted to tackle in the later studies. So, and we often say that communities could run programs better, but to what end? So if they were better program runners, but then they were doing programs that were not evidence-based, then is it a little bit like rearranging deck chairs on the decks of the Titanic, because it's really not going to get to the outcomes that you want. So that was definitely a concern of ours as we headed into the next round of studies. So the later studies began to really flesh out this full GTO logic model, from support to capacity to performance, but now we were able to add the level of fidelity of the programs that we were working with, and then actually the outcomes of the individual participants of those programs. So we adopted this sort of 2-year GTO training and technical assistance process that I kind of hinted at earlier. So you would start with your getting to outcomes training, and in the earliest steps of GTO, that's around needs assessment, goal setting, and, you know, honing in on a program. And then we would give people a training in a certain evidence-based approach. In the 2 studies that I'm going to talk about, in each study, everyone was going to be using the same program. So, you know, we would work with the staff to come up with desired outcomes for those programs, what they wanted to achieve with their participants. Then we would move on to the next batch here, which is we made plans around how to do fit and capacity. So trying to make sure that the program fit into their organization, that they had capacity to do it, and that it was fully planned. Then they implemented the evidence-based program. We worked with them to collect data, both on fidelity and outcomes. We then evaluated that or analyzed that data, created feedback reports, and then had sort of a continuous quality improvement and evaluation workshop where we went over all the data and made plans to improve the next round of the program, and where they kind of repeated the whole thing again. So ran the program, collected evaluation data, and then we ended with sustainability at the end. So that was sort of our approach in the next two studies. So, and here's how kind of it all fleshed out. So we did one study that was focused on teen pregnancy and one was on drug prevention. In teen pregnancy and in drug prevention, we were using boys and girls clubs. These are, if you're not familiar, these are clubs that basically have a lot of after school activities, mostly focused on recreation, some tutoring. They're in almost every community, you know, across the United States. So we focused on Alabama and Georgia for the teen pregnancy study and Greater Los Angeles in the drug prevention study. It was cluster randomized by state in GTO. And the basic model was evidence-based program versus evidence-based program plus GTO. So some sites got the training in the evidence-based program and then were just left to their own devices to implement it as they would saw fit. And then the other half got the GTO guidance and support on top. Same was true with the study in Greater Los Angeles. We collected that performance data that we did in the previous study, like again, how well they did all these different activities of the GTO model via interview and standardized ratings. But this time we added measures of fidelity in both places, in both studies. So we actually had people go to the sessions, observe them, and make standardized ratings on how well the curriculum was being adhered to, how well the delivery quality was, attendance. And then we actually surveyed the youth participants of the program. So in the teen pregnancy study, we had all sorts of outcomes on sex behaviors and also knowledge and attitudes about use of condoms. And then similar in the drug prevention study, we had drug behaviors and also knowledge and attitudes. So we had similar footprints of our TA, two half-time folks, either a master's or a bachelor's. The two programs, one was called Making Proud Choices, that's an evidence-based teen pregnancy program. The Project Choice, evidence-based drug prevention program. The GTO completion, how we actually did it was, as I explained earlier, it was a much more structured, systematic approach than we did in our earlier studies. We kind of stepped through, everyone got the same sort of exposure to all the GTO steps. We didn't necessarily let people kind of take an idiosyncratic approach as we did earlier. And so what we found was similar to before in our earlier studies was that program performance, those ratings of how well they did all these programs, was better for the GTO assisted sites. And also we found in both studies that there was a fidelity effect, that by year 2, the GTO assisted sites had way superior fidelity in running their programs. In the teen pregnancy study, we actually did find some better youth outcomes too, that GTO youth had better condom attitudes and intentions. Some of the other outcomes like sex behaviors wasn't significant. We didn't see youth outcome differences in the drug prevention study. And then some additional outcomes is we actually had an opportunity to go back to these sites in the drug prevention study and say, okay, so after 2 years post GTO, that means we'd sort of ended our involvement, you know, that choice program, are you still doing that? And so in fact, more GTO sites were still running the program even after 2 years after we had left. And we also did see that better GTO performance led to better program fidelity. So again, that logic model that we had connecting these things, we were able to kind of bring it all the way, you know, to the end, you know, especially with fidelity and somewhat with individual outcomes. So we find that, you know, GTO sites had better knowledge and performance and fidelity. And we really, I think the idea here is that highly structured evidence-based programs can get you some fidelity, but but sites need more support to get high fidelity, which is really what you want to get outcomes. About 26 hours over 2 years for each site. And also we did some additional work looking at sort of barriers and facilitators in the drug prevention study. And it was just by chance that GTO sites had sort of more barriers there at the start. And we were still able to get better implementation at those sites with GTO. And we also did notice that just being in the study as a control group caused some intervention bleed, because we had to call up the control sites and say, hey, that program that we trained you in, you know, when are you doing it? We need to come by and observe. And so we found that just being in the control group kind of probably dosed them up with a little bit of GTO inadvertently. And we know that in part because we created this third contact group in the drug prevention study where we just offered up free training to Greater Los Angeles youth serving organizations, trained them, and then like a year later with no contact whatsoever, we called them up and said, hey, you know that program that we trained you in? Did you do it ever? And we trained, I think, about 5 different organizations. No one had done any implementation of that program. So it's, you know, it's pretty telling that that is sort of, I think, the normal state of affairs, that people go to trainings all the time, but they rarely bring it back and actually utilize it. So even being in the control group where we were prompting you because of data collection concerns, seems like it was a little bit of an intervention bleed. We were able to show proximal outcomes in terms of youth outcomes, meaning sort of these attitudes and intention kind of behaviors and knowledge. And so it was very difficult to show actual behavioral outcomes in the youth. And that's because I think the base rates for both teen sex and teen drug use were very, very low. So it was hard to show improvement in that. But we were able to do that in the teen pregnancy study. We were able to show proximal outcome impact. And what was really nice is that so the drug prevention study was actually a replication in a sense of the teen pregnancy study. It was the same GTO delivery, same structure all the way around, but with a totally different program, totally different. I mean, they were Boys and Girls Club sites, but they were different sites. And so we were able to get most of the same findings with a different program and a different set of sites. So we felt that there was actually an instance where we were able to directly replicate, which is, replication is an important feature in science. You want to be able to replicate your results. So I'll end with, this is the Digital Scholars speaker series. And we are probably, a little bit digital, as I mentioned. We have digital versions of all of our tools so people can fill them in, in Word documents so they don't have to be working with paper. But there's definitely more that could be done. We have this greater idea that you could turn getting to outcomes into an interactive web-based platform where all the tools are shared and stored online. You can complete all your work online. All the guidance that you would have would be directly linked to all those tools. You could have other people who are maybe funding you to do some work to be able to look at the completion of your tools to see if you're on track. You could collect data in the system and then link that to tools to see if your fidelity is linked to outcomes. There's all sorts of possibilities about how this could really go digital. And we've actually tried to apply for some funding for NIH and haven't been successful so far. But that is, that is a hope someday that we could actually create a platform like that. If anyone has any ideas about that, I'd love to talk to you. And so if you're interested in more information about GTO, we have a ton of stuff online. This is the URL. We have all of our manuals are available for download for free. We have some archived webinar trainings for various steps within the approach that you can look at for free. And we have lists of all our scientific publications as well. So, feel free to check it out. And I will end my formal remarks there. You're on mute.
Great. Thank you so much, Dr. Chinman. That was great. And a nice overview of the GTO work that you guys have been doing, as well as what GTO is. And so if people are interested in following up, please definitely check out the website. I put it in the chat as well as a clickable link and get in touch with Dr. Chinman. So if you got some time, maybe we can go through a couple questions and then we'll wrap up. Great. Okay, so you talked a little bit about some of the difficulties with organizations implementing programs kind of after all the trainings, but I'm also wondering if you could discuss a little bit about just some challenges in general working with community organizations during the actual data collection phases, during the actual trainings of GTO.
Yeah, so all the skills and the activities that are involved in all the steps of GTO, a lot of the staff that are at these organizations are not really, they didn't get into their business for like doing evaluation. So they often don't have those skills. So, they mostly, it's like right in here or gets delivering. That's why a lot of the staff that we worked with got into the job that they got into, because either like they love kids and they want to help kids. And so they were very focused on just sort of what happens when you're in front of a child or a group of children. And it was harder, it was hard to kind of sometimes get their interest and their focus on sort of all the other aspects which we know make programs successful, like planning them well and evaluating them. And so that was definitely a challenge, but we were able to kind of make it happen with all the support and the guidance that we were able to have. And it's clearly something that you can't really do in like a month. It does take some time to meet with people and kind of be with them throughout the life cycle of a program. And so, and that's why we have that slide that sort of has, the driver, the person in the driving, and then you also have someone in the passenger seat. Like you need to be there through each part of the program, guiding them, giving them feedback, because like when you go through each of these steps, 1,000 decisions come up, and each one of these represents a different choice point with different trade-offs. And they might not know, because you can talk to people about a sort of a general sense, but then when it's related to their own organization, then they need guidance on how to take that general approach and apply it to their specific organization. So, some of these boys and girls clubs, like they didn't even have computers. And so, how do you manage in that kind of environment? So, a big part of what we do is sort of helping them tailor this, any program to their specific place while still trying to maintain high fidelity.
Thanks. And then on that note, was also a question about, this TA process, and I think you described it really well, but, given the fact that, you have to be with them every step of the way, what are kind of the implications of having TA remote, either through online chat or phone calls? And just, can you talk a little bit more about that?
So, yeah, and we have done some of that. And I think it's very doable. And I think, the pandemic has shown that, you can get a lot done over Zoom and these video calls. So I don't really think there's any way, I don't think there's any sort of downside to doing an approach. I mean, basically, they have to be somewhat available, on a regular basis. And I think whether that's a phone call or a Zoom call, I think, you do get the same, you can get the same amount of benefit. One of the things that we've been trying to do over the whole arc of this approach is we've tried to basically shrink down the amount of support that we give over, like, from study to study, to narrow it down to the most, like, what is the smallest amount of support we can give, but still have an impact. And so we are we're still testing that. We did some cost benefit analyses or cost analyses, and we did, it does add costs. And so it's something that, we definitely have to look at. But, what we did find is that even if you prevent just a few pregnancies or get just a few kids to not use drugs, societal cost wise, it definitely pays for itself. So I think, anyway, I think we can definitely do it remotely.
Great, thank you. And then how about just one final question, more of just a request. So could you share just a little bit more about future targets for GTO work? So, of course, Dr. Chinman and I have a grant that are trying to put GTO into schools. And so maybe you just talk briefly about that, but also just some other organizations, venues, settings where you see GTO being particularly helpful in the future.
Yeah, I think, I mean, the sky's the limit. I mean, we applied it to a number of different areas. I mean, I think one of the things that I really like about the grant that we're doing with, with Eric and Project Alert is to really kind of merge GTO and a specific approach in a more tight way to make it very seamless. So I think, our previous GTO approaches have kind of gone into an area and then we try to give guidance on a whole area like sexual assault prevention. What the Project Alert grant really provides an opportunity for is to really tightly wound GTO and all the guidance with a specific program. So the guidance, I think, becomes sharper and more useful for the people who are using that program. So that sort of answers your question in terms of, I mean, I like this idea of hooking up with certain program developers and making a very tight fit. And so we would all, we're very interested in kind of doing that with a lot of different folks. So that's not necessarily a content area answer, but more like a process area, because I think it can be more effective.
That's great. Yeah. And I know that, that study is the first time that GTO was used specifically within schools. Is that correct? Yeah.
Yes. Yeah.
Yeah. So, just thinking about other venues, organizations, locations where you can get the people that you're trying to get, this is a captive audience of students, that are receiving drug prevention education. So, I mean, if you're interested in that study, I put a link that shares a little bit more about that, but please reach out to Dr. Chinman or to us here at the Digital webinar series if you have further questions or even some ideas about partnerships. There's also a link to an evaluation, a very brief evaluation, if you do have a second to take that, that we put into the chat there. So I think we'll wrap up. Thanks very much to Dr. Matt Chinman from RAND for giving this great presentation on GTO. And please follow up, everybody, if you have any further questions or comments.
Thank you very much. Appreciate it.